tarde a todos aqui nesta sala. Continuamos com as simultâneas Hub Connect e nesta sala vamos tratar do tema Dr.TIS, Implantação de Telemedicina na Atenção Primária Brasil e Inglaterra, com Minal, Bakhai, diretora clínica do NTS, e Erno Harzhem, né, criador do Telessaúde do Rio Grande do Sul e membro da Universidade Federal do Rio Grande do Sul. E neste momento eu passo a palavra e desejo um ótimo trabalho para vocês. Obrigada.
Obrigada, Flávia. Seja bem-vindo a todos. Eu sou Jihan Zoghbi, sou CEO e fundadora da Dr.TIS. Teremos o prazer hoje de discutir um assunto bastante importante, que é a atenção primária, na visão de Inglaterra e Brasil. Vamos estar com a doutora Minal e o doutor Erno. A doutora Minal ela vai fazer a apresentação em inglês e o doutor Erno em português. Depois, cada um vai falar por 15 minutos. Depois disso, vamos ter a sessão de perguntas. Vocês podem mandar isso no chat e eu vou estar carregada de fazer a tradução. Hello, Dr. Minal. Thanks for your participation. Now I will pass the talk to you. You can share your slides with us, please, and start your presentation. Go ahead.
Thank you very much for inviting me. It's a pleasure to join you today. So I'm going to talk about the digital response in primary care within the NHS to COVID and how we responded to the pandemic. So I thought I would just start off by giving you a bit of background, setting the scene to describe where UK primary care was before we went into the pandemic. So primary care was already experiencing a significant shortage in its workforce, so our capacity was very limited. Waiting times for general practice were increasing. We had a big backlog of work due to high levels of demand and limited capacity, and our infrastructure was quite variable. Often it was based on old architecture, so we had very narrow corridors, small waiting areas, and this all meant that when we went into the pandemic, we had limited capacity within our system already, because the system was already under pressure. It required us to perhaps prioritise care to those that had greatest need, because we wouldn't be able to otherwise manage that surge in demand. The infrastructure, because it was not well suited to the high footfall of patients that we would traditionally have coming through our practices, meant that we needed to screen those people that needed to come in for face-to-face care, and particularly try and manage as many people as we could appropriately, remotely, reorganising our services so that people could be directed to places of safe care, so safe clinical settings. However, at the same time, we were beginning to develop more collaborative models of care delivery. So we were working in primary care networks. This is where groups of GP practices, usually in the same locality, were collaborating to meet the needs of our local population, as well as seeing some early adopters of digital technology starting to innovate and deliver new models of care. So if we could move to the next slide, please. And so it was about, during the pandemic, it was about building on some of these strengths that have been an essential part of our response. So first of all, we took on a total triage approach, which was often supported by online consultation systems to help maintain safe service delivery. Remote consultations were offered where appropriate alongside face-to-face care for those that needed it. And at the height of the crisis of wave 1, 85% of our consultations were managed remotely in general practice. We developed at-scale models of care delivery, so things like virtual hubs, where a group of clinicians would manage remote consultations on behalf of a group of practices, usually a primary care network or wider. And therefore, we were sharing our workforce, our resources and our workload. And this was particularly important when there were surges in demand or loss of capacity, particularly due to sickness. We implemented a virtual ward model And this used digital communication pathways with patients to enable remote monitoring, particularly remote monitoring of symptoms and oxygen saturations of our COVID patients that were being managed in the community. And this enabled us to pick up early signs of deterioration and intervene very quickly. And emerging evidence evaluating this service is really positive, suggesting mortality rates as low as 1%, which is a real success. And we've been sharing learning within our primary care community, but also wider. So using communication platforms digitally to facilitate this, enabling us to both respond in a more timely way to emerging evidence and make decisions based on need. And the pace and the scale of this change has been phenomenal. And it's been underpinned by grassroots innovation, by collaboration, by having this learning culture with a permission to do attitude that's been driven by our local leadership. I think it's worth remembering that this program of work, introducing digital tools, online and video consultations, digital pathways, has always been a 4 to 5 year program of work within the NHS. We've sort of tried to squeeze that into about 4 months. And so just to put that context of the scale into context, pre-COVID, less than 3% of our GP practices had a video consultation solution available, and about 30% had an online consultation solution available, though our data suggests that perhaps that only made up 1% or less than 1% of total consultations that were being conducted in practices. And now we have 99% of practices have a video consultation solution available. Over 90% have an online consultation solution, and we're seeing over 600,000 submissions or requests of online consultations a week. And it's been really great to see this growing confidence with colleagues wanting to keep more remote consulting outside of a pandemic situation. 88% of colleagues are saying that. So that's a real positive in the way that clinicians have adapted to these new ways of working. But I think it's also worth calling out that this pace of change has meant that we've done things differently. We've not done them in the usual order that we would normally do to support this level of transformation, such as co-designing those local pathways with patients more, developing better user interfaces and developing experience, research on understanding best practice for use, establishing a training program for clinicians. And so we are carrying out all of these elements now. And we've got a large-scale program of work to optimise and evaluate to redress some of these side effects of doing things at such pace. And also recognising that this is much more a transformation program than a technology program. Really, nationally, we're funding implementation support using that kind of quality improvement methodology to optimise and embed these digital pathways into primary care. If we could move on to the next slide, please. So one of the key changes in the way that care is being delivered is the adoption of this total triage model. And the aim of this model is to reduce avoidable footfall into practices and protect patients and staff from the risk of infection. And so total triage means that every patient contacting the practice first provides some information on the reasons for contact and is then triaged before having a consultation. And while it's entirely possible to do this just by telephone, online consultation systems as well, using them together, leverages further efficiency and benefit. So patients can send in a request at any time of day without travelling to the practice, without waiting on the telephone, and they fill out an online questionnaire. It gives them the time and the headspace to detail their problem. The systems themselves can signpost patients to self-care or to other community services that don't require a GP, and they can, or otherwise they capture the history and send it to the practice securely. Patients will then, requests will then be directed to the right care professional within the practice with administrative queries being filtered out, and they can then receive a response from the right person in the team using a modality that is tailored to their needs. So that could be a message, a phone call, a video call, or a face-to-face appointment. What we see from the data is that about a third of requests can be closed through a message, which is really efficient for practices. And this approach really helps to ensure patients receive care from the right person or service at the right time. So maximising use of our resources, building in continuity of care with the right person, and minimising the risk of exposure to COVID for both patients and staff. And I think it's really important to emphasise the patients that can't go online or choose not to, then we still maintain those non-digital routes. So in person or on the telephone, patients are taken through the same process by administrative staff, using a short template. And of course, there will always be exceptions like our vulnerable patients. But this really does help to ensure that there is equity in access for both digital and non-digital users, and everybody benefits from this system. And it can also free up phone lines for those who choose not to go online. And the early evidence evaluating this is suggesting that practices that were familiar with this approach, particularly pre-COVID, were able to demonstrate resilience by responding more flexibly to the demands of the pandemic, adapting quickly, undertaking more remote care without significantly impacting the total number of consultations that they delivered. And interestingly, the evaluation that's been undertaken, the sample of practices that were looked at, there were an increased number of consultations in our older patients, over 75s, not just the younger patients, which does suggest both that this can be an inclusive model, but also we shouldn't make assumptions about who can and can't use digital. If we could move to the next slide, please. So this is the data on video consultation use. So video consultation use peaked in April, May, particularly when we were in lockdown. But as you can see, there's been a steady decline in its use since lockdown restrictions were eased. And this decline is likely to be related to an increase in face-to-face consultations. It stabilised at around the 50,000 mark per week, which when you compare to telephone consultations is actually quite small. So what this suggests is really that video consultations does have a place. It's a very useful tool, but actually most consultations can be managed through a telephone call. But I think it's worth emphasising that when you talk to patients, a lot of patients report that they would prefer to have had a video call rather than a telephone call, particularly due to the therapeutic benefit of seeing a clinician, even if it's through a remote medium. If we could move to the next slide, please. So this is the data on online consultations, and as you can see, there's a very predictable pattern in the demand that we're seeing. So Mondays and Tuesdays are our highest levels of demand. This mirrors non-digital modalities of demand as well. And if you deep dive further into this data, you can see that most demand comes in during core hours between 8 and 2 p.m. And why this is really important is that this has really helped the front line flex capacity to match times of peak demand, but also match skills to times of peak demand. Again, really making sure that our limited capacity isn't wasted and is used in the most valuable way. If we can move on to the next slide, please. So some of the key learning has been that a communications strategy is absolutely vital. So patients need clear information about how to access the services, an explanation of why things are working differently and what to expect. And this needs to be both national and local. So nationally, we launched a Health at Home campaign with videos and guidance on how to use a video consultation and online consultation and what to expect. But also local messaging is equally important. And we would urge commissioners to do this on behalf of practices, so it doesn't need to be duplicated many times locally. Patients' main concerns are particularly centred around, will they be able to consult with their regular clinician? Is the solution secure and private? And is this a barrier to access? So really, it's really helpful to explain to patients that this is a decision that's been made by the whole team. This is not just administrative staff taking on a gatekeeping role. Help them understand the why, so keeping them safe, but also reducing waiting times, having to not wait on the phone, and also enabling them to see the right person, but also providing reassurance that face-to-face care is available if they need it. But in particular, that a remote consultation isn't a lesser option. It is just a different way of providing care. And because it's something that patients aren't often used to, that may need further explaining. I think the other thing to state or emphasize is that patients trust practice staff. So encouraging that same messaging from all staff is really important. And that seems to be the most effective way of promoting use of these solutions. I think another challenge is virtual team working. So particularly where members of the team are working remotely, focused effort is required to maintain that cohesive team, particularly where teams are less well developed. So staff need support both personally and professionally to avoid isolation, exclusion, and maintain that cohesion, providing space to surface issues, to have peer-to-peer support, talking about those grey areas, those difficult cases, consistent access to formal and informal clinical supervision for trainees, because it can be harder to notice gaps, and also trying to create some routine with regular team huddles, sharing learning, and matching the modality to suit the different purposes and preferences of staff. And I think also really important, this applies to staff that are working at home, but also in the practice building, because that social interaction has been reduced because we're working more remote, doing more remote consultations. And I think finally, just to really emphasize that quality personal communication matters no matter what the modality is. There is no one size fits all. So it's about jointly agreeing on an acceptable consultation method with the patient, taking into account their needs, the circumstance and local risks of COVID. But also it can be harder to assess non-verbal cues and emotion remotely. So really checking and confirming with patients that you've understood correctly, that you understand the patient's expectations, being really clear on next steps, and not rushing. So spending time building rapport, active listening, space for questions, and particularly explanation and information giving, because our experience tells us that a detailed telephone or video consultation takes at least as long as a face-to-face consultation. If we could move on to the next slide, please. The next one after that, please. So, how do we make this transformation? So I think the first thing is that this is a continuous service improvement initiative. It's not implementing or deploying technology. And so really having that mindset. At the moment, we're carrying out an evaluation of the support that's needed, and very much key messages are that people need hands-on support, quality improvement and analytics expertise, and moving away from just a technical focus, because this is not just deploying tech. And we need to accept a culture that it's not going to be perfect first time, and it will require iteration. We need a clear process for procurement with aligned standards. So we've got a single procurement framework that we're developing for purchasing online and video consultation solutions, and a single process for managing suppliers with aligned standards across the board that can be used across NHS organisations broader than general practice. So we can start thinking about procurement at system level. So patients don't need to learn how to use a different system if they're consulting with their GP versus an outpatient clinic versus a community service, or having to download multiple apps. And we're having to have multiple communication strategies to help guide and teach patients how to use these different technologies. We need to create an environment which encourages grassroots innovation to thrive, and to facilitate those collaborative models of care. In the UK, we issued COPI notices to remove some of that red tape around data sharing across health and care organisations that facilitates collaborative working. We've set up digital first accelerators that are working locally and co-designing with patients and practices new pathways and integrating services. For example, integrating general practice with community pharmacy, and developing communities of practice to share that learning more widely. There's also a bureaucracy review underway, because one of the key positives of the crisis was that we had some headspace to innovate, because certain target or assurance-based activity was paused. And so we were able to involve our whole teams in changing processes, we improved morale, and we were able to engage with these wider networks to make decisions and to collaborate. We're progressing a learning system, so it needs to be driven by data, evaluation and feedback, really an informed system. So a lot of the technology is still in its infancy, and it will need to continue to develop to better meet practice and patient needs. Some of the key things that have come out in terms of improvement are that we need better integration of these systems into our clinical systems. We're doing an evaluation on the design, usability and accessibility of these solutions. Some solutions can be quite lengthy for patients to complete. So what would be best of breed for patients, but also understanding what the information needs are of practices and how they should be presented in a way that is meaningful and helpful to get to the crux of the problem for clinicians. We need better signposting within some of these systems, and that feeds into the integration work that we're doing around minor ailments, so we can make maximum use of our resources outside of the general practice setting, and also continuing to improve infrastructure, so particularly equipment and Wi-Fi to support the use of these tools. And alongside this, we're standardising data that's collected by suppliers to really support commissioners investing in the right products, and understanding the impact of these different solutions, being able to compare them, but also when we're evaluating, we're focusing on what aspects of the approach have led to benefit, and for whom, and in what circumstances, and what changes are needed to have more inclusive models of care. I think it's worth also emphasising that relationships have been key during the pandemic, local collaboration and leadership and that bottom-up approach, and fostering new relationships with community colleagues as well as our acute trusts, and brilliant team working, checking in and out with our teams, really working as high-functioning teams. So it's about maintaining that leadership to drive this forwards. If we could move on to the next slide, please. I think when we're looking at digital maturity, we need to look broader than just the best or fastest technology. And so what we're developing is a digital journey planner to help people understand all of those elements that are required, critical success factors for transformation. So taking that more comprehensive approach, so thinking about people, training, knowledge transfer, culture, organisational structure and governance, change management support, roles and responsibilities, analytics, and mapping this actually to a support offer that people can go to, so they know how to make progress. And so we're ensuring that the funding that we've put in place for these programs is used to support these key areas, and not just investment in the technology, and really driving that outcome-based delivery approach by building in the right data and analytics into the program, so we can actually monitor outcomes beyond just utilisation and have a much more nuanced idea of practices in deprived areas with non-English speaking patients versus practices with a younger population and older population, and trying to get a much better feel of the types of solutions and transformation that's needed locally. Can we go to the next slide, please? I think this is just about, again, showcasing some of the innovative ways that the technology has been used in the pandemic, so really to support proactive care. So our patients that we're shielding, our patients with long-term conditions, things that people have tried and used that have been really successful have been ensuring that, first of all, the information is coded in our systems consistently. So we're able to extract data to identify those at most risk. And asthma, I think, is a really good example where that innovation has been used to support. So we know that 2/3 of asthma deaths could be prevented. We know that 3/4 of patients with asthma would like to have a digital solution to support their care. And it's simple measures like making sure people are on a preventer inhaler, making sure people know how to use their inhalers, and that people know what to do when their asthma gets worse are the key things that would reduce and save reduce deaths and save lives. So if we can code patients and extract information on a weekly basis around who are high-risk patients, and then proactively we've been contacting those patients to complete an online assessment, carry out some remote monitoring, we triage and ensure that they are managed by the right person at the right time and have that timely intervention using the right modality, because we know with a lot of our asthma patients, most of them don't attend their annual review, which is a once a year face-to-face review, because it doesn't suit them. The system has not been built around their needs. We're sharing their records with them, empowering them to participate in their care, sending them digital action plans so that they have them handy on their phone when their asthma gets worse, summarising key points of the consultation, providing digital education, and then scheduling follow-ups. We can schedule automated follow-ups, so we can ask them to complete, for example, an online consultation within a specified time frame. And we're now thinking more broadly, using video group clinics and also our PCN role. So we have care coordinators and health coaches across our groups of practices, which could have a big impact on this risk stratification and providing that more holistic educational piece around long-term condition management. And if we could just move to my last slide, please. So digital inclusion, if we could move to the next one, please. I think it's really important that with all of this innovation, we don't leave anybody behind. And health inequalities have been starkly highlighted by COVID, particularly in the UK. So it's really important we consciously design for equity and inclusion. We know that in the UK, 11.3 million people lack basic skills to go online. 4.8 million people don't go online at all. And so we have a widening digital participation programme. And some of the and they've been working with some of these people with protected characteristics and have demonstrated benefits by improving digital inclusion. They've reduced GP appointments for long-term conditions by a quarter, so 25%. They've demonstrated a £6.40 return on investment for every pound that's invested in digital inclusion, which is huge. And increased use of self-help and community services as well in patients that are empowered to use digital tools. And the way we're doing this is we're using partnerships, so really working with our community partners to reach people and deliver digital health training. We are sharing initiatives because there's loads of great initiatives already being developed. We don't need to reinvent the wheel. So creating platforms to share those so they can be adapted locally. Training digital champions up, so using our social prescribers, local champions as facilitators, setting up digital hubs, but setting them up in places that are comfortable for those people to attend. So, for example, homeless patients were telling us we don't want to go to the library to access a computer. So, you know, these hubs have been set up in cafes that they normally frequent or in hostels, having free access to data to use NHS websites like nhs.uk, improving the accessibility of solutions that we've sort of mentioned before, but, you know, captions, speech recognition software, and just basic things like the language, raising awareness through national and local communications, translating resources into different languages, and really using data to understand the levels of digital exclusion and the reasons for digital exclusion locally. Is it because of poverty? Is it because of language? You know, what are the key areas that we need to be tackling when we're looking at designing our local initiatives? And then using the funding that we have available to design an inclusive model to support people. Thank you.
Thank you, Dr. Minal, for sharing with us this rich contents. Fantastic, né? There's a lot of lessons for us to learn here in Brazil. Muito obrigada, pessoal. Desculpa não ter tradução, mas depois vamos disponibilizar esse vídeo com tradução após esse webinar, né? Eu vou só compartilhar com vocês um vídeo que o nosso colega Pedro vai passar e vamos para nosso colega Dr. Erno, que vai falar sobre atenção primária aqui no Brasil. Está sem som, Pedro.
A vida não será como antes. E a adaptação é fundamental para seguir.
Bom, obrigada, Pedro, né? O som está meio ruim. Agora vou convidar o Dr. Erno Harzhem para compartilhar conosco a sua experiência em telemedicina na atenção primária. Por favor, Dr. Erno, fique à vontade de compartilhar seus slides.
Boa tarde a todos que estão nos assistindo. Boa tarde à doutora Minal, a Jihan, ao Pedro, a todos que participaram da organização desse webinar. Eu vou colocar apenas uma imagem na tela e vou tentar ser breve para a gente cumprir bem o nosso prazo e, ao mesmo tempo, conseguir algum grau de objetividade. Eu acho que a gente teve uma excelente apresentação da doutora Minal, tanto do ponto de vista da estratégia de serviços digitais para atenção primária no NHS, no Reino Unido, como também aspectos de implantação e operacionalização dessa estratégia, né, de serviços digitais para atenção primária. A gente tem algumas semelhanças com o Serviço Nacional de Saúde britânico, né, semelhanças conceituais, mas poucas semelhanças operacionais, muito poucas, né, até porque boa parte do sistema de saúde britânico é prestado por entes privados a serviço do público, principalmente na atenção primária, né, praticamente toda ela, enquanto aqui no Brasil a gente tem praticamente o oposto, né? Quase toda a nossa atenção primária é uma prestação estatal de serviços públicos, né? E isso é uma diferença fundamental de um sistema para o outro e traz uma grande lentidão para o nosso subsistema de atenção primária, para a nossa rede de atenção primária, conseguir avançar em algumas situações de qualificação da clínica e principalmente centralização do cuidado nas pessoas. Do ponto de vista teórico, da produção de conhecimento, o grupo de pesquisa do qual eu faço parte, a gente acredita que o sistema de saúde que deveria ser de hoje, não sei se ele já é assim em algum local do planeta, deveria, obviamente, ser muito centrado nas pessoas, com uma rede de atenção primária muito forte cercando a elas, é esse círculo branco que está em volta do núcleo central dessa figura, e a atenção especializada e hospitalar deveria ter uma fronteira muito tênue entre ela, e a gente não exigir que as pessoas tivessem fluxo físico dos seus corpos entre a atenção primária e a atenção especializada hospitalar, a não ser que elas necessitassem realmente de uma intervenção física. A atenção primária de amanhã, pelo menos, deveria ter a potência de conseguir trazer para dentro dos serviços físicos de atenção primária, de maneira virtual e através da telemedicina e da telesaúde, boa parte do que hoje a gente configura chamar atenção especializada. No Brasil, a gente criou uma verdadeira gincana, um verdadeiro labirinto do fluxo das pessoas no sistema. As pessoas não entendem que fluxo físico elas devem percorrer para ter a sua necessidade assistencial resolvida. É completamente obscuro, com pouca transparência e pouca informação, um pouco por ser mal organizado também, né? E demanda uma necessidade de idas e vindas a diferentes serviços que muitas vezes são para cumprir apenas questões burocráticas. Hoje a gente tem condições de ter point of care da maioria dos exames laboratoriais necessários para uma ótima prática de qualidade baseada em evidência, atenção primária. A gente consegue trazer boa parte da necessidade de referenciamento virtualmente através da telemedicina para dentro do serviço de atenção primária e ficaria basicamente a questão dos procedimentos para serem realizados em outras estruturas físicas. Incompreensivelmente, né, tem regiões inteiras do Brasil que estão novamente construindo grandes centros de especialidades, gigantes, estruturas físicas que em 5, 10 anos vão estar completamente desatualizadas, vão estar sofrendo o efeito do tempo e não vão ter mais a qualidade física que tem hoje, a semelhança, por exemplo, do que existe aqui em Porto Alegre, de grandes centros aí construídos na década de 70. O Brasil teima em seguir a história que os outros países já percorreram com os mesmos passos para construir o seu sistema de saúde, quando a única chance que a gente tem de ter um sistema de saúde sustentável e que realmente atenda às necessidades das pessoas é saltar em direção ao futuro. A gente não tem que reconstruir a atenção especializada que a gente nunca conseguiu ofertar no SUS, nos moldes presenciais e cartoriais. A gente tem que saltar e integrar a atenção especializada à atenção primária para conseguir entregar isso perto das pessoas, até porque, num país heterogêneo e continental como o nosso, exigir fluxos físicos beira uma questão quase absurda. A gente tem alguns exemplos de sucesso em relação a intervenções que foram feitas nesse sentido. Uma das principais é a diminuição da lista de espera por consulta especializada aqui no Rio Grande do Sul. Em 2015, havia mais de 200 mil pessoas esperando por uma consulta especializada em Porto Alegre, do interior do estado do Rio Grande do Sul. 2 anos depois, esse número era de 60 mil pessoas, e a cada mês, antes da intervenção, esse número crescia em 5 a 10 mil pessoas por mês. Então, 2 anos depois, a perspectiva era ter 350 mil pessoas esperando por uma consulta especializada, e o número de pessoas que esperavam nesse momento era só de 60 mil pessoas. A gente fala só, frente ao nosso universo de filas e listas de espera não inteligentes, né? Ter listas de espera não é um problema, desde que elas sejam orientadas por critérios razoáveis e inteligentes de resolver o problema clínico dos pacientes. A intervenção que foi realizada foi uma regulação clínica eficiente, não uma regulação administrativa. O Brasil faz muita regulação administrativa nas suas listas de espera e associada à regulação clínica, a discussão dos casos entre médicos de família, médicos especialistas, resolvendo o caso das pessoas dentro das unidades básicas de saúde. Isso virou uma intervenção nacional através do PROAD, com diversos hospitais do PROAD construindo o Regula Mais, que é um projeto nacional de intervenção das listas de esperas em algumas capitais brasileiras. O primeiro hospital que participou disso foi o Sírio-Libanês, fez um processo de aprendizagem com o Núcleo de Telesaúde do Rio Grande do Sul para desenvolver essa tecnologia, e hoje ela está em implantação em diversas capitais, pelos 5 hospitais que fazem parte do PROAD SUS, mas com a velocidade que nos caracteriza, né? A velocidade que nos caracteriza, infelizmente, não é a do Senna, é mais a do Rubinho, né? Que parece que vive mais no nosso coração, né? A gente prefere o folclórico que não chegava com a velocidade que deveria na linha de chegada e esquece que a gente já teve Piquet, Fittipaldi e Senna sim, que eram pessoas que sabiam acelerar, até em condições adversas, e alcançar os seus objetivos de vitória. Dentro do espectro da questão da Covid, a gente teve um grande avanço no Brasil, né, que foi uma permissão regulamentar transitória, tanto do ponto de vista legal, né, uma lei aprovada no Congresso Nacional permitindo a telemedicina, como também em norma infralegal por portaria do Ministério da Saúde. Mas ambas trazem a questão da transitoriedade, que a telemedicina está amplamente permitida no Brasil enquanto durar a pandemia. Por que esses dois dispositivos foram realizados com esse texto, né? Pela pressão corporativa médica do Brasil, que há alguns anos vem sendo um grande empecilho para a gente conseguir avançar de maneira mais rápida rumo a um sistema de saúde mais equitativo e mais efetivo, usando a telemedicina para conseguir romper com o dilema entre acesso, qualidade e custo do sistema de saúde. Eu não tenho dúvida de que a telemedicina é capaz de aliar esses três conceitos que sempre pareceram impossíveis de serem colocados juntos, né? O dilema de Oregon diz, né, entre acesso, qualidade e custo, escolha 2. Eu acho que a telemedicina é a ferramenta para a gente poder escolher os três, mas a gente tem que olhar para quem realmente interessa, que são as pessoas, e não os interesses corporativos. Num país do tamanho do nosso, e com esses dispositivos de gestão tripartite, ente federal, estadual e municipal, sendo a saúde uma execução no encargo dos municípios brasileiros, não é o Ministério da Saúde que deve fornecer de maneira única as soluções para todo o país. Até porque a gente vai ter municípios em etapas diferentes de capacidade de evoluir nesse sentido, e a gente precisa atender essa heterogeneidade para produzir, né, a coesão federativa que o Brasil precisa. Mas é essencial que o SUS, por parte do seu gestor federal, consiga disponibilizar as ferramentas essenciais para permissão da execução da telemedicina na atenção primária. E tem feito isso, né? O eSUS é um prontuário de produção do próprio Ministério da Saúde, né? Na verdade, é um sistema de informação da atenção primária que também eletrônico embutido para os municípios que quiserem fazer uso. Cerca de 11, 12 mil equipes de saúde da família hoje usam a opção do prontuário eletrônico do eSUS e cerca de 15 mil usam outros tipos de prontuários eletrônicos, mas com conexão à base de dados do eSUS, tendo dados tanto centralizados no Ministério da Saúde, como com a gestão do primeiro ano da Secretaria de Atenção Primária descentralizado para os municípios, para conseguirem fazer a gestão da saúde populacional. Através dos dados que hoje nós temos no eSUS, qualquer município com prontuário ou sem prontuário consegue, por exemplo, ter as listas de espera, as listas de busca ativa de pacientes pelas condições que quiserem, né? Crianças que estão vacinadas, crianças que não estão vacinadas, pessoas que têm hipertensão estão consultando, não estão consultando, desde que, óbvio, as equipes de saúde de família dos municípios apropriem os dados nos sistemas. É possível trabalhar com uma informação digitalizada. Concorrente a isso, o DataSUS fez um grande movimento de integrar, durante o ano passado, 5 eixos de informações em saúde: vacinação, prescrição, atenção primária, internações hospitalares e procedimentos de alto custo, na estratégia denominada Conect SUS, que ainda não está a pleno, mas deve ter um sumário de informações desses 5 eixos que podem permitir o tráfego da informação entre os níveis assistenciais de maneira mais fácil, incentivando a ampliação da telemedicina. E no âmbito da Covid, a Secretaria de Atenção Primária também, em março, conseguiu lançar o consultório virtual em saúde da família, disponibilizando uma ferramenta de comunicação entre os pacientes e os profissionais de saúde, das equipes de saúde da família, para permitir a teleconsulta, não só médica, como de enfermagem e de odonto, com certificação dos profissionais incluída nessa oferta, e com um trânsito de informação que permita, como a doutora Minal salientou, que as pessoas recebam não só a prescrição do medicamento, se isso ocorreu, como a solicitação de exames, mas também um sumário do que foi discutido e do que foi definido naquela consulta, para a pessoa ter o seu da consulta que ela teve. A gente tem alguns entraves, porque esses sistemas não se comunicam, o sistema do consultório virtual não está integrado plenamente ao sistema do ESUS APS, então tem que haver duplo trabalho dos profissionais nesse sentido, mas isso tem sido a rotina, inclusive, dos grandes planos de saúde, na saúde suplementar brasileira, da velocidade que a Covid nos impôs, conseguir ofertar a telemedicina de maneira pragmática e de uma forma com que, principalmente, as pessoas, os pacientes, conseguissem ter acesso sem grandes obstáculos. Para finalizar, né, em paralelo a essa questão de potencializar a atenção, a telemedicina na atenção primária, nós lançamos, no final de março, uma estratégia de atendimento de pessoas com sintomas de síndrome gripal e Covid, através do Telesus, que, por meio de inteligência artificial, fazia rastreamento robotizado de pessoas doentes no Brasil, identificando pessoas com sintomas de gravidade ou situações de risco. Esse atendimento era transformado num atendimento pré-clínico, telefônico, entre profissionais de saúde, enfermeiros e médicos e os pacientes. E durante 45 dias, esse sistema conseguiu rastrear 22 milhões de pessoas, nas quais encontrou 4 milhões de casos de sintomas respiratórios, das quais 1.100.000 pessoas foram derivadas automaticamente para o sistema de atendimento pré-clínico, impedindo, evitando que milhões de pessoas consultassem presencialmente e transitassem pelas cidades do Brasil com sintomas respiratórios e transmitindo Covid com alta efetividade. Infelizmente, na troca de gestão, esse sistema foi abandonado pela gestão atual do Ministério da Saúde, quando a sua capacidade operacional, nos 6 meses que estava previsto, era rastrear em metade da população brasileira os sintomas de Covid, e o próximo passo, que já estava organizado, era incluir a testagem com PCR de todos os sintomáticos, para a gente conseguir ter um sistema de contact tracing no Brasil, automatizado via inteligência artificial e telemedicina. Mas parece que as decisões mais baseadas em evidência e em tecnologia não são o forte, né, do que hoje nós temos na gestão federal da saúde no Brasil. Então, a gente perde uma grande oportunidade de conseguir, inclusive, evitar um número enorme de mortes que poderia ser evitada por sistemas baseados em tecnologia, centrados nas pessoas e que fortaleciam a atenção primária. Todo o relatório desse sistema era enviado para as secretarias municipais de saúde, para as equipes de saúde da família poderem seguir o monitoramento das pessoas identificadas como doentes, né? O que era um fortalecimento entre a abordagem por tele e a abordagem presencial. Como também disse a doutora Minal, a gente não pode ter apenas ofertas tecnológicas, nem todos os pacientes, todas as pessoas vão se adaptar a elas, nem todos os profissionais de saúde vão se adaptar a elas, mas é um caminho que não tem volta, que a gente deve facilitar e que a gente deve insistir para que venha a ser como é hoje no Reino Unido, através do sistema do NHS 111, a maior produção de consultas no Reino Unido se dá por esse sistema e não mais pelo sistema presencial, e o Brasil se beneficiaria muito de ter um sistema semelhante como que foi criado no Telesus. Era isso, muito obrigado, eu fico à disposição para perguntas.